Hello, and welcome to CDCES's podcast, The Huddle, Conversations with the Diabetes Care Team. In each episode, we bring you perspectives, issues, and updates that elevate your role, inform your practice, and ignite your passion. I'm Danielle McNary Moran, Marketing Communications Manager at CDCES. One of the topics we've been particularly interested in lately as an association is the importance of integrating diabetes technology into primary care. Today, Kelly Postiglione Cook, Director of Clinical Services at Beta Bionics, will speak with Dr. Sean Oser, Associate Professor in the Department of Family Medicine at the University of Colorado School of Medicine, and Associate Director in their Primary Care Diabetes Lab. They'll speak on how automated insulin delivery systems, including the iLet Bionic Pancreas, can be more widely utilized in primary care and how diabetes care and education specialists can play a role in this implementation. And I thank Beta Bionics for sponsoring today's episode. Sean and Kelly, welcome to the Huddle.
Thanks so much. It's great to be here.
Yeah, thank you for having us.
This conversation is going to be a bit unique in that I know you both actually have some questions and discussion for each other. So I'll jump in every now and again as well. But Kelly, I'd love to kick off the conversation with some of your questions for Sean.
Thank you. Dr. Oser, you've been a major advocate for deploying diabetes technology in primary care. Can you talk about why this is so important?
Absolutely. So I think it's critically important because there's a misconception, I think, held by many that most diabetes care is accomplished by endocrinology or diabetes subspecialists. But in reality, about 50% of adult type 1 diabetes care in the United States is delivered in primary care and 50% in endocrinology, but we still do a big chunk of it. And when it comes to type 2 diabetes, primary care takes care of about 90% of type 2 diabetes, which is the biggest majority of diabetes in the US. So it's really important to include primary care. It's really important to make sure that patients, wherever they get their care, have access to the best treatments and the best technologies.
Absolutely. And I think it's important that primary care providers have the right tools to be able to meet those ADA standards of care.
So not only is it important because we want to be able to get the best care to most of the people, but where the care providers are located is really important also. So we know that most of the population in the US is concentrated in the bigger cities and on the coasts, but there's still a significant amount of population in all the other places too. And in those cities and coasts, there tend to be endocrinologists. And it turns out that about 25% of all of the counties in the United States have an endocrinologist there, at least one, adult, pediatric, doesn't matter, but at least one of some kind. But 75% of counties don't have even one endocrinologist. On the other hand, 96% of US counties have at least one primary care clinician there. Physician, MD, DO, physician assistant, nurse practitioner, but someone is practicing primary care in 96% of US counties. And even where there are counties that don't have one, every single one has at least one primary care provider, one county away. So if we want to get people the care that they need and not make them travel great distances to do it and get their care where they want to get their care, it's important that we be able to do this in primary care too.
Absolutely. Automated insulin delivery is advancing rapidly. Can you describe how the iLet works and your experience deploying it in primary care?
Absolutely. So the iLet Bionic Pancreas provides really fully autonomous insulin delivery, and it incorporates data from a continuous glucose monitor, which gathers glucose information from the patient in real time. And it sends that information to what is a very, very fancy insulin pump. And like other insulin pumps, it delivers insulin, but it doesn't follow a program that someone had to figure out all the settings for and set in the first place, which is quite a bit of work to do to set up, I would say, more traditional insulin pumps and actually most of the automated insulin delivery systems or hybrid closed loop systems that exist. The iLet's unique in that you need to set up the CGM, which is true for any of them. And then you need to input this one really easy to find number, which is the patient's weight. And then you press a button or slide a slider to go and start. It starts learning right away. It uses the math that informs the manual calculation of all of those settings that we have to do with the other systems, but it uses it for us and it does it automatically. And in reality, those equations give us sort of rough starting points of where to think about starting insulin delivery. And they require a lot of revisiting and refining and everything. And that takes a very long time in clinical practice before the iLet, because the iLet does some kind of refinement every 5 minutes. Every single glucose reading that it gets from the continuous glucose sensor it's adjusting, it's making a dosing decision, and critically, it's learning. So it's always adapting. And even when it's figured out, those optimized settings, which again, take a long time with other systems and with previous insulin pumps, for example, and also with injections, with shots, the iLet, not only does it figure it out, but it also keeps adjusting, keeps refining forever. And I know in real life and clinical practice, it can be relatively infrequent that we revisit those settings once we figure them out, and we just sort of let them go on as they become imperfect again. So it's a beautiful combination, I think, of being able to start it simply, have a lot less work to do that. My hypothesis going into a study that we did was that it would be quicker and more straightforward to get started for people and supportable in a primary care setting, but that in endocrinology settings, it should require less effort and less labor from the staff to get it going, and it might increase throughput and get more people in both settings, both primary care and endocrinology, onto better technologies faster.
Absolutely. Can you describe your study deploying the iLet in primary care?
Sure. I love this study. We're fortunate enough to get a grant from the Helmsley Charitable Trust, which is a philanthropic organization that supports research in type 1 diabetes, especially. And we know about all of the research and all of the data that have been produced around the iLet before, including actually before it was an iLet, when it was a prototype that used other insulin pumps and it wasn't yet a manufactured product. And their results were always amazing. It always did such a good job, and that incorporates the algorithm, which I didn't mention. So actually it's a series of algorithms. So between the continuous glucose monitor and the insulin delivery system itself, which I think it's a little probably disingenuous to call it a pump because it's much more than that, but it's essentially an insulin pump. Using the CGM data and the ability to deliver insulin in very fine increments and to make those adjustments, it relies on, very critically, it relies on several algorithms to take that glucose data to make adjustments to the insulin, to make dosing decisions. Knowing that the previous work that used other insulin pumps, continuous glucose monitors, and their algorithms before it was even an iLet, the results were amazing, but all of the work had been done in not only in endocrinology centers, but really in academic medical centers that did great work. And that's critically important, but it was really sort of like the best of the best. And understanding that it needs a CGM and it needs the patient's weight, which again is very easy to get. The hypothesis was that this does not need to be done only at endocrinology centers or only at academic medical centers, and we can do this in primary care. So let's do a study and test that. So we did this study where we wanted to recruit 20 participants. It was not a very big study at first because this had never been done before. We got approval from the FDA to use the iLet in an investigational trial, which is of course necessary for any of the studies up to that point because it wasn't approved for use commercially yet. And we wanted to stack the odds against ourselves in primary care. So we were going to recruit 20 participants from primary care, and we were going to have an endocrinology center recruit 20 participants, and we were going to compare ourselves to them. But we really wanted to stack the odds further. So the endocrinology center that we essentially compared ourselves to was the Diabetes Research Center at Massachusetts General Hospital, which was heavily involved in actually developing the original algorithms and software and product, heavily involved in every single study ever done on this device. So we wanted to compare ourselves against the most knowledgeable, the most experienced, really the best. And we had no experience with it. We knew about it, but we'd never used it. We hadn't been involved in any of the studies. And we wanted to further stack the odds against ourselves and require that all of the participants that were recruited from the endocrinology center were previous or current pump users, whereas those that we recruited from primary care all had to be multiple daily injection users of insulin, not pump users. So we did that, and we got 20 participants and they got 20 participants. We put them on the iLet for 14 days, and then we crossed over. There was an iLet treatment period of 14 days, and there was a usual care treatment period of 14 days. So we compared the participants' experiences using the iLet to their experience on their routine care, and they underwent those two treatment periods in random order. So half the participants started on the iLet and half started on usual care, and then they all crossed over to the other after 14 days. And on average, what we were very pleased but not very surprised to see is that the primary care participants' glucose numbers really changed. From higher levels, they got lower. And what we were, again, not too surprised, but very gratified to see is that so did the endocrinology participants. And there really wasn't any difference. we naive primary care folks at our site had the same results as the super experienced experts at the endocrinology site. And one of the things that I take away from that is that it really seems to be that it's the device and its algorithms and everything that went into it, much more so than it is who's at the helm managing it, because really the device is doing the management, not the clinician.
And then you also, during that study, you looked at in-person versus telehealth.
We did, yeah. So within our primary care cohort, half of the participants we trained on the iLet and we got them started in person. We had study visits in person to start and to finish. And half of them were telehealth, people that we never met face-to-face a single time ever. And we trained them to use the iLet to do all of the hands-on things without ever being in the same room as them. So we did this on HIPAA-compliant video meetings, and it was challenging, but turned out to be rather successful, training someone to use a device that at its core is a complex piece of technology, but there's a few moving parts that people need to know how to set up their CGM, to set up the device, to fill an insulin cartridge, to do an infusion set change, and to do the maintenance of the device. And they were great. We were just as successful training those participants by telehealth as we were the ones in person. And there was no difference between the in-person and the telehealth groups. Mass General did the same thing. They had half of their participants in person and half by telehealth, and the results again were the same across groups. So even with fully remote training and support, never meeting the person in person and never touching the device together or being able to point to their device because they were somewhere else, it seemed to work just as well.
That's pretty great. I think especially for some of those rural settings that you discussed, that can definitely make things easier for access.
Yeah, I totally agree. We had some participants who were in rural areas and in a couple of cases would have been a couple hours drive from their nearest endocrinologist, underscoring the point that we need to be able to do this in primary care and to offer it from primary care also. And they did not live as far from primary care, but some of them were still a good distance away. It wouldn't have been convenient for them, for example, to have to come in to do any troubleshooting or anything. And they really appreciated the opportunity to do this from their living room at home. And they did great.
That's great.
So the results that we collected, our primary outcome was, it'll sound like a strange one, I'll explain it, was the proportion of each group that achieved an average glucose on the iLet of less than 183 milligrams per deciliter, which sounds like a very kind of random number. But a glucose of 183 corresponds to an A1C of 8.0. And we wanted to see what proportion could achieve the equivalent of an A1C less than 8. We chose that particularly because that is a very common quality measure used in a lot of the primary care world by health plans and health systems, for example, and NCQA, which puts out the HEDIS reporting measures and is the one that we're all sort of beholden to prove the quote unquote quality of the diabetes care that we're providing. So what proportion of our patient populations can achieve an A1C less than 8? So we wanted to see if we could do that on the iLet because it would be a very meaningful primary care outcome. Not that I believe that A1C less than 8 is the target for most people most of the time, but that's the quality measure that we have. So we found that 97% of people during their use of the iLet in our study achieved an average glucose less than 183, again, corresponding to an A1C less than 8. And number one, that's amazing. That's not normal, I would say. Those aren't the kinds of numbers that we report from our usual patient practices. And number two, it wound up not being very helpful because it's such a huge number. So we wanted to get a little bit closer. We looked at one of our secondary outcomes, which is an average glucose less than 154. And that corresponds to an A1C of less than 7. So we had 64% of our participants achieve that during their use of the iLet, which is pretty notable because we know that fewer than half of people with diabetes in the US actually achieve an A1C less than 7. So to be able to get there very quickly in just 2 weeks and to average less than 154 during that 2 weeks was really astonishing. The average glucose went down by 17 milligrams per deciliter during their use of the iLet, and time in range increased by 11%. And at the same time, there was no change in time below range or sensor measured hypoglycemia. So we lowered people's glucoses. We did not do that so much that we caused any increase in low glucose. And again, our results were the same, whether they were in person or telehealth, whether they were primary care or endocrinology. It was really pretty astonishing. We did a sub-study, a qualitative sub-study to balance those quantitative results where we interviewed our participants from the primary care cohort who were using the iLet during the trial. They completed brief interviews to share their perceptions and experiences. And across the board, they all reported improved quality of life. They improved psychosocial kinds of outcomes. They felt less stressed. They felt less burdened. They had some trouble, interestingly, adjusting to letting go of control and trusting the device. But once they were able to do that, and they all were, it just took some time, they really felt that nice to let something else bear that burden for them. Remember, I mentioned that all of our participants in the primary care cohort were multiple daily injection folks. All of them had had diabetes for a pretty long time, actually. They were required to have diabetes for at least a year to be eligible to participate. And there was one person who had been diagnosed about 2 years earlier, but most of them had been diagnosed like 10 or more years earlier. And it's pretty hard, I think, to escape, as an adult with type 1 diabetes, it's pretty hard to escape care providers who at least offer, if not pressure, transitioning to a pump. And they all had been suggested to think about, or even, I'm being gentle, or had been pressured to switch to a pump or shots. And these were the holdouts. These were people who had resisted all of those previous efforts and were still on shots at this point. By the end of the trial, several of them, number one, wanted to keep the device and were very disappointed to have to give it back. Number two, several of them transitioned to other insulin pumps of different types that were available at the time and continue on insulin pump therapy today and finally gave up their multiple daily injections.
Yeah, that sounds like a really comprehensive study and super informative to hear about, especially coming from someone like myself from the non-clinician perspective. So thank you for that. Sean, you've given us a lot of good information about the study, about the role that AID can play in primary care, and the iLet Bionic Pancreas. I'm wondering, where do the diabetes care and education specialists and other healthcare professionals in that realm fit in? I'd love to hear from you both on how you think that the role of the DCES is shifting when it comes to automation advances.
From where I sit, I see it as a great opportunity for diabetes care and education specialists because you don't require the prescriptive authority that some other products may require to be able to really help someone get great outcomes. When someone is using the iLet, you're not relying on going in and changing settings typically to improve outcomes. It's more of a coaching. So now instead of sitting there and tweaking settings throughout a visit, you're in a coaching session with the patient. You're teaching them how to use the device appropriately, how to interact with the algorithm to make sure that it's getting the best data that it can so that you get the best outcomes that you can. But within that, there's more opportunity to focus on things like a healthy, well-balanced diet, exercise, some of the other things that we kind of run out of time to talk about because we are ingrained in doing the pump setting adjustments and things like that, where all of the coaching around interacting with the iLet system is just basic diabetes self-management. It's announcing meals the right amount at the right time, kind of basic coaching there. But hopefully it's a time saver around the settings. But I think the big thing is, again, it doesn't require prescriptive authority because you are just coaching a patient. So it's a great way for diabetes education centers to support primary care providers. And maybe if there's endocrine clinics that they're supporting as well, it's a great opportunity for those educators to help to support their patient populations in a more robust way without requiring that prescriptive authority.
Yeah, thanks, Kelly. I agree. And I would add that I think it offers new opportunities and maybe increased opportunity to touch more people, to advance more people's care. So it's fairly commonplace for endocrinology practices to employ a diabetes care and education specialist or more than one. And from other national work, we know that there was a survey of primary care providers nationally, and I forget if it was 37 or 38%, but it was certainly less than 40% of respondents. This is a sample size of about 600 respondents nationally and very broadly representative of the whole nation. So about 37 or 38% of primary care clinicians have access to a DCES, even part-time, but more than 60% have no access to a diabetes care and education specialist in their practice. It's also very common in that scenario for the diabetes care and education specialist to be shared among multiple primary care practices. That's certainly the situation I had before I came to Colorado. When I was at Penn State, we had one diabetes care and education specialist who served 7 primary care practices. And a similar situation here in Colorado, where I am now, the opportunity to deploy diabetes care and education specialists in primary care is a really important one. They don't need to live only in endocrinology practices, and they really need to be available in more primary care practices, just like I was saying about access to care. I think access to education is important wherever you get your care. We're also not going to be putting any diabetes care and education specialists out of a job by having technologies that get easier and easier to start and to support, because there's so many people with diabetes and so many people who are going to continue to need education. Something like the iLet, a great way to be able to advance treatment and to advance management. There's still types of education and types of support that are important with that, just like there are with other technologies, other AID systems, other CGMs, the ability to serve more patients and to meet their needs, because it doesn't take maybe so much effort or so many manual calculations as it used to, I think is really important. So really spreading a very important resource to more people can only be a good thing.
Agree. The other place where I think a diabetes care and education specialist comes in is that with the iLet, you don't do specific carb counting. Another opportunity for diabetes care and education specialists is that meals no longer have to be math problems. It's very common that we hear from educators that their patients struggle with numeracy and being able to correctly count carbohydrates. So with the iLet, they can announce meals in a qualitative fashion. This is breakfast and this is my usual amount of carbs for me, whatever that means. So the complexity is not as significant as it is with some other devices, but it also eases the burden for the user in that they don't have to do that math problem along with the diabetes care and education specialist, because they are no longer teaching that math skill. It's more about just, again, recognizing that qualitative meal size. And is this usual for me, less or more, which would be about 50% less or 50% more.
That's a great example, Kelly. Thank you. One of the things that we experienced in the trial was people having questions about what is less and what is more, and having clear guidance about what to tell people about that was really helpful. And they caught on really well. It took some education up front because it's so different, so radically different from what people are used to in managing their type 1 diabetes. And that freedom from the strict carb counting to this qualitative method of being carb aware was really freeing for a lot of people.
It's great to hear.
So we heard from more than one participant, actually, that they're so used to looking at a plate of food and just seeing a bunch of different numbers that they have to figure out. And then they just see those numbers on the plate, that getting away from those numbers while they were participating in the trial and using the iLet was really a totally different experience. And they saw food on their plate again.
Yeah, we actually discussed this in a recent publication. Meals no longer need to be math problems. Some understanding of carb counting or carb awareness is still important for AID users, especially when the goal is to maximize time and range. A continuum of carb awareness is the framework for using carb information to inform insulin dosing and to improve glycemia, starting with the ability to identify foods containing carbohydrate and being able to quantify carbohydrate foods as servings or assign meal sizes. So simplifying that carb counting versus determining grams of carbohydrate, but really that complexity of determining the exact grams of carbohydrate, that increases the burden of diabetes care in general. So being able to relieve users of that is really important.
And I think there's a great tie back there to where I practice in primary care also, because just like I mentioned, not necessarily having as much time or as many resources to determine all of the pump settings that the other systems generally have always needed. Another big education need is to have people really fluent in carbohydrate counting when that's necessary. In this case, that isn't necessary, right? We can do more limited carbohydrate education, as Kelly was describing, just to be aware of what foods contain carbs versus what don't, rather than does it actually contain 37 in the serving or is it more like 52? The difference between 37 and 39 might not be important, but the difference between 37 and 52 is pretty important. And with the iLet, you can just cover that by, is this usual for me, or is it more, or is it less? So the burden of education is a lot less, but it also, I think, helps the patient to focus on some of the things that are, it's all important, but some things may be more important than others. And people clearly have limited capacity. I certainly do have limited capacity to process information and to turn it into action. So how much of my mental capacity needs to be used on knowing minute carb counting details versus knowing other things that are all important in my diabetes management, for example, and being able to free up some of that mental capacity so that I can use it for other things, or even things that are not diabetes, right? I can turn some of my attention back away from diabetes management to the rest of actual life, live a richer, fuller life.
Yeah, sounds like finding some balance between diabetes and everything else.
Thank you both for sharing. And Kelly, thank you for talking about that publication. We'll be sure to link that in the show notes. Sean and Kelly, I've really enjoyed listening to this conversation between you both. I think it's going to be really interesting and relevant for our listeners. So thank you. And I wanted to leave us off and see if there were any final thoughts that either of you would like to share before we close.
I think this is a really great opportunity. Sean's study showed that this device can safely be used in a primary care setting. Patients got great outcomes using the iLet Bionic Pancreas in that setting with both in-person and telehealth trainings. And they were able to use the meal announcements appropriately, again, get those great outcomes. So it's a great opportunity to get technology to more patients without the complexity of those baseline settings that are really a hindrance for a lot of providers in feeling comfortable with using autonomous insulin delivery. And then there's no need to come back to settings and keep adjusting them moving forward. So I think the way that this device is used is really important in a primary care setting. And I hope that we see more adoption towards that in the future.
Yeah, it was wonderful to do the study. It was very gratifying to see what we thought might be the case turn out to be the case, at least in the limited setting that we did it. We're super excited to be kicking off a bigger study that's a randomized clinical trial using the iLet in a larger population of people. This one will involve not only type 1 diabetes like the first one did, but also people with type 2 diabetes who were treated with insulin. So we're very excited to be kicking that off shortly. We have our approval from the FDA. We have approval from our institutional review board, and the steps are all falling into place to get started. And we're going to be looking for participants nationally who might like to use the iLet, and where their primary care provider believes that it would be beneficial for them, they should be able to be put on an iLet for 3 months in this case, not just 2 weeks. We'll get some more primary care only results. So we're super excited about that.
Well, Sean and Kelly, thank you so much again for having this conversation with us on the Huddle today. And thank you again to Beta Bionics for sponsoring today's episode.
I'd really like to take the opportunity to thank the team at the University of Colorado and the Primary Care Diabetes Lab, who were absolutely amazing at supporting this trial, performing this trial. The collaborators that we had, our colleagues at Mass General, their Diabetes Research Center, who were fantastic partners, and the Helmsley Charitable Trust for funding the trial, and the folks at Beta Bionics for providing the devices and the supplies. And we couldn't have done it without the effort from everyone. And really, we're just thrilled with the results and excited for this next trial coming up.
Thank you for having us.
Yeah, thanks, Danielle. This has been a great opportunity to talk together.
And thank you for listening to today's episode of The Huddle. Check out the show notes for references and resources related to this episode, including a link to another of our recent podcasts on a similar topic. And for more information on the latest in diabetes technology, including AID systems and CGM use in primary care, be sure to visit our Dana Tech platform, which will be linked in the show notes as well. Being an CDCES member gets you access to many resources, education, and networking opportunities. Learn about the many benefits of CDCES membership at adces.org/join. The information in this podcast is for informational purposes only and may not be appropriate or applicable for your individual circumstances. This podcast does not provide medical or professional advice and is not a substitute for consultation with a healthcare professional. Please consult your healthcare professional for any medical question.